Okay. Thanks. No, I didn't want absolutely to stop the colleague. I was enjoying actually very much listening. The studies that have been performed, we actually mainly focus on longitudinal strain. And therefore, in these updates that I was asked to give you, I will focus on longitudinal strain and on these 4 points, which has been indeed in the last decade really strengthened over the years. The first one is certainly that this measure has been much more validated. Automated software has been introduced to make it more and more easy to be implemented in a routine of an ecolab, and therefore it's become also more reproducible. And we have all the reference value that we can use to use it in the clinical practice. Therefore, this makes it not anymore like a new advanced measure only for research, but really something to be included in the clinical practice. So in these regards, I don't know if you know, but there's been a very big task force of the European and an American Society of Imaging, together with the industries, to try to see if these measurements were similar among different vendors, Philips, GE, Siemens, etc. And after this task force has worked and has given really indication on how to measure these particular parameters, we have seen that indeed it has really, really improved over the time. By using all the proprietary software, you can see that now the coefficients of variance among the different vendors is much, much lower. So if you use one machine or the other one, actually you can obtain these measurements very easily and to be reproducible among the different ones. So in that sense, it's very important to use the same approach. So when you want to do longitudinal strain measurement, try to always have the same approach. So acquire the appropriate image, check if indeed the frame rate is enough, at least more than 40 frames per second. Place in an automatic way your landmarks, and then when it will be the automatic endocardial border detection, check that is adjusted correctly your ROI without going into the pericardium, by including the myocardium from the endocardium, and the track quality. If you actually follow these steps, you can have a really good reproducibility and reliable measurements, although a certain amount of experience is always necessary. So here, indeed, they said that when you want to use this measurement in your lab, try to have some experience first, train with several cases, and then you are ready to go. Then the second point I wanted to update you on is the fact that indeed, thanks to the fact that we can use it more and more in the clinical practice, we have now more and more data how important is this measurement, not only for diagnosis, but also for risk stratification of several different patients. And this is beyond left ventricular ejection fraction that of course, is an important measurement, but has a lot of limitation. And this is why I would like here to give you a small overview on the application of this measurement, especially in the setting where ejection fraction is normal. So you think that that patient has a normal systolic function, but actually there is an important impairment going on, and that would be important to detect. So one first case is the case of left ventricular hypertrophy. I guess you see it very often in your clinics, where you see important hypertrophy, therefore a normal ejection fraction, but you can imagine that that myocardium is not working well. And when we do the global longitudinal strain, so of the left ventricle, you can see that indeed already in the bullseye, it should be all red, and instead gives you low values and even areas where it goes to pink or to blue. With a total ejection fraction of 75%, that is normal, my GLS of 8%, that is very low, because we know that normal values are in around 20%. So here, the GLS, the global longitudinal strain, was able to depict the myocardial dysfunction, while the ejection fraction not. And why is that? Well, there's been some studies that they showed that indeed in ventricle with thicker wall and smaller volume, the longitudinal and circumferential shortening are the ones required to maintain the ejection fraction. So they are working to give the ejection fraction, but actually the systolic function is already reduced. So this is why, for example, in the recommendation for the multimodality imaging in patients with hypertrophic cardiomyopathy is really crucial. In the recommendation is one of the key points that you should assess global longitudinal strain, because it will give you an idea of the myocardial function, in this case dysfunction, and therefore risk stratify these patients. But you can also, of course, differentiate to differential diagnosis with patients with just a bit of hypertension, of maybe amyloidosis. I'm not sure how many you see in your country, but this is an emergent disease that has been more and more diagnosed, where you can see that indeed the bullseye of the GLS, of the global longitudinal strain, is much, much more different. Goes down already for hypertrophic cardiomyopathy, and even more down for the amyloidosis. Other diseases where maybe you don't have hypertrophy, but you might have myocardial dysfunction is also, for example, in the setting of diabetes. We know that it exists a diabetic cardiomyopathy, which has some component of ischemia, but also of direct toxicity, which could be detected, for example, with cardiac MRI spectroscopy that analyze the amount of triglycerides in the myocardium, which are indeed toxic and lead to cardiomyopathy. And in this sense, strain might be the one really able to detect this alteration at the level of the myocardium, maybe even with a component of ischemia, maybe even a component of the concomitant hypertension, but it will be able to detect this dysfunction. And this is a study, for example, that we have done really in comparison with CMR, where you can see that indeed there is a very strong relationship between the global longitudinal strain value, the myocardial fibrosis, and the myocardial triglycerides content. So you might be able really to identify subtle initial abnormalities of the myocardium. Same concept goes for the cardiotoxicity. This is also a very important topic. More recently, we had the new ESC guidelines which really for the first time were the first guidelines really giving indication of how we should follow patients undergoing chemotherapy. And as you can see here in the recommendation, for the first time actually in the guidelines history, we have the GLS as a measurement really integrated in the recommendation, where they say that if there is a decline in more than 50%, you should define a cancer therapy related cardiovascular toxicity. Or the same also if, of course, you have in the ejection fraction. But the GLS is certainly the most sensitive and subtle and really can detect left ventricular dysfunction. In this case, you can see that there is a nice figure that really highlights the use of transthoracic echo in this patient where GLS is really included. And this is just one case coming from my patient clinic where you can see that indeed after 4 cycles of chemotherapy in a relatively young patient without no risk factor, you can depict the decrease in GLS from 22 to 18, 19%, while the ejection fraction 62% not significantly changed over time. We could not depict it when just using standard echo. And this is why now in modern trials on chemotherapy, cardioprotective therapy is actually suggested and really based on the changes in these parameters. So this is, for example, the SUCOR study, which you can see that the design really considered this measurement for decision making. And very similar here, you can see in this other study how very important is to assess not only the ejection fraction response, but the global and longitudinal response. So it's something really to integrate in your clinical practice when you have these patients under your guidance. And finally, another possible application could be in valvular heart disease. You have listened previously now cases with aortic stenosis. So in this patient, of course, when symptoms occur, we have indication for surgery. But when there are no symptoms, sometimes there is already a certain myocardial dysfunction that might become irreversible if you don't act in time. So here, for example, there have been a meta-analysis, but to indeed highlight the fact that there were many studies assessing this issue, which show that in patients with asymptomatic but severe aortic stenosis, assessing the GLS, the global longitudinal strain, can really help us stratifying this patient, even if the ejection fraction is preserved. And you can see here that including all the other studies, the GLS of around 15-16% could really help us in identifying those at high risk that might need more attention, more follow-up, and eventually the treatment, the intervention. And this is why already an expert consensus document suggested that if you have a GLS that is preserved, you can be reassured and just follow up this patient. But if you have a GLS that is decreased, even if the ejection fraction is preserved, you should think carefully what needs this patient needs. Maybe a magnetic resonance imaging to really look at the properties of the myocardium, or really think of an intervention. Finally, if we go a little bit further, I wanted to update on the fact that these measurements might need correction for loading condition, because it is loading dependent, although the ejection fraction is much more. And there's been some proposal how to further optimize the measurement of strain with the afterload, the so-called myocardial wall indices, where indeed adding to the GLS the measurement of the brachial pressure, which is actually the afterload of the left ventricle, would better reflect the left ventricular end systolic pressure, and therefore also the measurements, correct the measurements of the strain. So this is probably a little bit more advanced, more research level, but is to think that we should always consider the condition of the patient, what is the blood pressure when we are measuring these parameters. And this is, of course, very true in case of aortic stenosis, because it's not only the brachial pressure, but it's the valve giving much higher afterload to the ventricle. So in this case, we could correct eventually for a gradient of the aortic valve, add this to our calculation, and correct therefore the strain also for the afterload. But this is again a little bit more on the research level at the moment. But most important, the final part of the presentation, I would like to stress the fact that we can use strain measurement not only on the left ventricle, but also on the other chambers, which have been increasingly reaching attention because they are also very important for our patients. So the first one is for sure the left atrium. We are shifting more and more from measuring the size of the left atrium to going towards the function of the left atrium, because we all know that the atrium can be also very sick. I've been hearing more and more about what we call atrial cardiomyopathy, fibrotic remodeling and electral remodeling of this chamber. And therefore, assessing the function will give us much more information than not just measuring the size. And for function, we might be also very elegant and looking at a reservoir function, conduit function, or contractile function. The reservoir function is actually how much the left atrium expands during systole, and that is a lot of influenced by the atrial compliance, but also partially related to systolic function, because when the left ventricular contracts, will pull down the atrium and facilitate its filling, and therefore the reservoir function. The conduit function is instead purely influenced by left ventricular relaxation when the mitral valve opens, while the contractile function is really the booster function of the left atrium, the contractility of the left atrium. So this can be measured with the strain, with the speckle tracking echocardiography, and you can see you will obtain, while placing your region of interest on the left atrium, a curve a little bit like this. So it will be positive during systole, so there is an expansion and lengthening of the left atrium. Then when it will start emptying in the left ventricle, will reduce again, reaching a plateau until you have the final kick of the left atrium, and therefore again a contraction and towards the zero line. So in this, there's been a lot of effort to standardize how to measure it. This mascot study really suggests some technical issue how you measure it. So for example, to set the R-way as a null line, but this actually is now overcome by the fact that most of the vendors provide automated measurements. So actually you have to just put 2 points and it will get you the measurement in really few seconds and obtain the curve that I just showed you. So there you can use indeed mainly the reservoir strain, which is the one that has been the most used in the studies and for which we also have normal reference values. Here is the NOR study, who showed that for the reservoir strain, you have obviously a certain range of measurements, but you should use 19 to 23% as a lower limit to start worrying about, let's say, that the patient has some problem. For that, indeed, there has been a lot of application in all different patients where this measurement could make a difference and could help you understand what's going on with your patient and what is his risk. And the two most important, I think, are in the setting of diastolic function, something that I think you face every time. Diabetic patient, hypertensive patients, old patients, sick patient, or patient with a sort of HFpEF. And you can see that at the moment, the strain has been really recommended to improve your diastolic dysfunction assessment, because in a lot of them will be indeterminate. And here in this algorithm, you can see that you might use left atrial strain with a cutoff of 18% to really better understand if the filling pressure are elevated, yes or no. So if you follow the algorithm, just start with the classical measurement, the EA ratio, then use the EE prime, the TR velocity, and LA volume. But in a lot of them, unfortunately, is our experience in the practice, you will get into an indeterminate classification. And here is where LS strain can help you and tell you if it's elevated filling pressure or not. So very, very useful in the clinical practice. And the other one, I think, is also the stratification of the risk of stroke. In some patients, they have idiopathic stroke. We still don't know why they had it, if they have maybe subclinical atrial fibrillation that we could not depict. But certainly the function of the left atrium could really help you in risk stratifying this patient. There have been several studies that have shown that the LA strain could really help you in identify the patient at more risk, or at least have a new tool to play with in the stratification. The other chamber that has also gained a lot of attention instead is the right ventricle. It's very difficult to assess RV function. It's very much load dependent. The image with echo are more difficult. So certainly having a new tool that could help you in assessing this patient could be very useful. And you can apply indeed the strain to this chamber, either including the septum as in this example, so we call global right ventricular strain, or only the free wall, so really focusing on the right ventricle, and then we have the free wall longitudinal strain. To do that, as in this example, you really need an RV focus view because the measurement otherwise could be a little bit strange, but still, if you have also normal for chamber view, you can try and see the values. And these one are indeed, again, a little bit the range or normal value that you can use for these measurements that you can see are higher than in the left ventricle, and indeed around 25% approximately, as you can see in this case, using either 6 or 3 segments. So again, also in this case, this strain value has been applied in a lot of different patient settings, patients where there was RV volume and pressure overload, heart failure, pulmonary blood pressure, valvular disease, congenital heart disease. So of course, it's a very huge group of patients where you could use for assessing better RV function. Here, just to be limited, I give you just a few examples. This, for example, is a 30-year-old woman with systemic sclerosis, which you know at high risk for pulmonary arterial hypertension. And you can see that from the echo, it seemed she had a good RV function. And of course, as you can see, high pulmonary pressure, a TR gradient of 67 millimeter mercury. And here, if we see the function, you can see that initially the strain was preserved, 24%, but then over the different follow-up of her pulmonary pressure, you can see that we have a decline, really clear decline in the RV strain, which helped on understanding that her RV function was not coping very well with such a high afterload, while the normal longitudinal function visually remained the same. So this is a good tool to better understand these patients. And similar if you have more volume overload rather than pressure overload, like in this case, when you have a massive tricuspid regurgitation, you see this signal, you seem that the RV is doing fine, is contracting. It's true, but because of course most of the blood goes to the right ventricle and it seems to have a good ejection fraction, but when you do the strain analysis, you have minus 15, so much depressed as compared to 25, 23%. So it's telling us that this ventricle is not as healthy as we are thinking and is actually suffering from such a problem with the valve. Obviously, also in this setting, as I mentioned, we might want to correct for this afterload, which can be indeed different according to the situation. So also in this case, we might see if the ventricular arterial coupling is good or not, if therefore that right ventricle can cope or not with those afterload. And a way of doing pretty simple, which you could do, is just using the TAPSE, or maybe just substitute the TAPSE with the strain and correct for your pressure measurement. So in that case, you can really assess if the balance of the right heart is good or not. And I really suggest some of this nice review to look how to do that. So I hope in conclusion, I give you a good overview of how much strain now is available for large clinical use and really in the clinical practice. so far that it reached a recommendation document, the guidelines, and we should really be familiar with this measurement and try to use it in our daily routine. And obviously, we look at the future, at the updates, and possibly also measuring with other different modalities. But I hope I showed you enough the application already for the present. And I thank you very much for your attention and be happy to take any questions if you have.